Welcome to the first ever virtual alumni meeting in a town hall. And my plan today is to, as always, serve you. Whatever you want to talk about, I'm happy to talk about. And just to give you some time to search your minds on what you want to have in front of us today, I will give you a relatively brief update on the school. Next slide. There it is. So the structure of the school is really anchored in the land grant mission. If you are a student of Tom Jefferson, like I am, you would recall that in 1787 he authored that other document, that lesser-known document from his pen, the Northwest Ordinance. And that has been a brilliant departure from what up till that time was a European way of educating people in professional fields such as medicine or law, even engineering, and which was predominantly private. And the Northwest Ordinance allowed for, not just allowed, it actually mandated that every new territory west of Ohio will have a piece of land that will be given for higher education. And in Jefferson unmistakable prose, he phrased it, the reason for that was that the knowledge and education is necessary for good governance, but it's also necessary for happiness. It's pretty Jeffersonian, isn't it? So that's where we start. The land grant university takes, in my understanding of it, its relevance from service to the community, from being anchored to the legacy of the school, from the deliverables that we can bring to the community. And the front door of what we do is patient care. And we support this patient care in ways that's different from others by being able to be fluent from the bench to the bedside, to be able to understand, COVID-19 is a good example of that, understand the unknowable and then make it into a product that's helpful to somebody who is suffering. And the way we bridge the transgenerational necessity of continuing the legacy of the school, that's where the education fits in. The architecture is across the school in 27 departments, 2 campuses, 1 medical school, 2 campuses, Duluth and here in Twin Cities, 17 centers, and the incredibly powerful statement that we do educate majority of the physicians that choose to practice in state of Minnesota. It's also very important that we educate approximately the same number for our friends to the west and south, and somewhat lesser number, but still very significant, for our friends to the east. Next slide. The academic medicine is really the distinguishing factor. So the way we look at where we are and who we are, personally and professionally, individually and as a group, we actually don't know. We don't know, and we all know this from their personal experience. I don't know whether I'm a good bone marrow transplant physician until, I can look at my patients and look at my peers and see in their assessment, where I stand. I don't know whether I'm a good researcher until NIH tells me that my grant was funded. It was renewed the R01 this year, and that's how we know where the Google map of the individuals and the groups and the institutions are. So one of these metrics is the NIH funding, and I am disproportionately proud of the U-shaped curve. It is 3 years to the day today that I have taken the burdens of this office, and over that time we were able to jump 6 or 7 ranks in the ranking of the NIH, and there are 150 plus schools in the United States. So being able to be in the second decile of this ranking in itself is an incredible achievement of the faculty. And what it took was support. What it took was tailored support for individual investigators. Anyone who has ever had an R01 grant or P or something, knows how incredibly difficult it is to get the first, and almost equally difficult to keep it. So people need support. People need to be entering in a permissive environment that values research, but not just in a sort of a gestures, but in real support that will help them square the sometimes difficult balance of clinical work, your family, your teaching, your lab. There are very many distracting, if you will, or dissipating factors, that are pushed on that glorious phenotype of a physician scientist that, in my opinion, is the backbone of a academic institution and academic medical school such as ours. I want to also be clear that this is a lagging indicator. What is the leading indicator is the knowledge that is being brought forward, and that is where we are investing time and treasure as we go. Next slide. Focus is everything. That's not, I admire many people. Another one after Tom Jefferson would be Steve Jobs, the person who in 2000, who changed your lives, and my life as well. So 2001, that was when he came with iPod, and 2007 with iPhone. He changed everything. And one of his things, that he said, focus is not what you do, but what you don't do. So 3 years ago, I came in front of the chairs of the department chairs of the school and said, you can choose anything you want for the school. You are the leaders in the school. You lead this as everybody who knows me knows that I think of leadership not only as a servant leadership, but also as a team leadership. So I asked my department chairs to be leaders for the school. And part of that responsibility is that they choose the foci where we go. So on the right-hand side, these are the three that we have outlined 3 years ago: cancer, neuroscience, and biomedical engineering. And going deeper, in the areas that, as you probably know, we have been known for and reasonably good, and want to become excellent. And then in the left side of the slide are some of the new initiatives that will complement this. One is the Masonic Institute for Developing Brain. One is in the population health. We have seen this year an enormous incentive, in my opinion, to invest in the you can call them social determinants of health. You can call them political determinants of health. You can call them moral determinants of health. But nobody would question that vast majority of investment and vast majority of impact in clinical care is not in clinical medicine. It is, can you get on the bus and get there? Do you have the right food, at home? Do you have the mental health support that is important? Why is it that if I prescribe a medication, not just me, any physician, only about 60% of people will take it? That's unbelievable. If I think about veterinary medicine, just the thing that you would take your dog or cat to a vet, get a prescription, and then not use it is almost impossible. And yet in human medicine, we face this non-compliance, if you will, if you like the term. I don't, but the fact that people just don't do it, as a tremendous burden. And the last one is the Infectious Disease Institute, which again has to do with the inspiration of the COVID-19. Next slide. Everything changed with COVID-19, but not necessarily in how people may see, as I started with this existential freefall, and the components that people would identify as the polarization of the society, as the erosion of the societal discourse, and public and private narcissism, and of course the pandemic and the economic consequences of it. That's true. But at the same time, I choose to see how incredibly noble has been the positives, the confidence in science, the value of expert and expertise, and the unquestionably democratization of access to science, with the Zoom, with the virtual visits in clinic, and the speed, the sheer catalyst of a necessity made a lot of things that we do, as you see here for COVID-19, which could be the protective equipment that we have put together with the Institute of Engineering and Medicine and College of Design, the clinical trials that I'm happy to talk about more if you want to, but we have been seen as a information and action hub for COVID-19 since March. The cohorting, in the Bethesda Hospital, the research that went into understanding the pathophysiology of COVID-19, all of that is just incredible. Example of how we can work better together, and how the people that are positive and are asking, why not? Why not do this? If the society and community needs it, rather than finding ways of why not to do it. So why to do it? These why notters, are the people that have been almost like self-selected through this process, and we all know, how that is. That the intrinsically motivated people, they just do fine, almost under any circumstance. The extrinsic motivation advances the quality and the rapidity with which these teams work, because everything is done in teams, and everything is done across the hierarchy, from the administration, from the full professors, all the way to the students. Next slide. The best way, I think, that I can update you on how things are, in that grassroots, in this Nemawashi layer of our school, is to turn to a brief video of the current medical students. Be much better with the sound. Maureen? Christine? Okay.
My name is Christopher Siever. I'm a second-year medical student, and my hometown is Rugby, North Dakota.
My name is Colleen Bell. I'm a fourth-year medical student, and I'm from St. Louis Park, Minnesota.
I'm Michael LaRock. I am a third-year medical student, and I am from Grand Rapids, Minnesota.
My name is Kriti Prasad. I'm a second-year medical student, and I'm from Albuquerque, New Mexico.
Both my mom and dad worked in the hospital. So my brother and I have one older brother. We're both first-generation college students, and Thomas, my older brother, actually is a physician. He finished medical school a few years ago, and I love the medical school here. So I just kind of took a whim and threw in an application, and fortunately the U of M took an opportunity on me, and I couldn't be happier.
Everything I saw at the medical school, like when I toured and interviewed and stuff, I was really impressed with it all. I would describe them as kind of a leader in the medical field. I think they have a long, rich history of being involved with medicine, and to be able to be a part of that was something that I thought was kind of special.
I'm not sure exactly when I decided I want to be a doctor, but my dad says that I've been talking about it since I was a little girl. I know that when I was in high school, as soon as I was 14, I started volunteering at the hospital every week.
I definitely want to practice in a primary care environment. I've always been interested in a person's whole story, and so I feel like disciplines like internal medicine and family medicine really lend themselves to a more like holistic kind of approach.
Many schools now use what we use, which is called a holistic admissions process, where students' lived experiences are as important as their MCATs and their grade point average.
Every professor I've had, they're all just phenomenal with working with you. They want the best, so they really do look out for you.
And the never-ending battle that a single individual can never, ever know it all, and that even though we look at individuals who are experts, and they absolutely are experts in that set area, there are so many other areas and so many different interactions between specialties that it just consistently blows me away just how much there is to know about a human being. But after months of doing this and repetition and seeing it in different settings and seeing it in practice question form and list form and lecture form, you start to understand it in an actual like clinical sense or a pathology sense instead of just memorizing things.
I've always felt really strongly that I've had a lot of opportunities in life, and I need to use those opportunities to try to make the world a better place for other people. People are super important to me, and to me, it's the most important thing is like human connections and relationships. And of course, I care a lot about patient care and clinical medicine and making the diagnosis and the treatment plan. But I think for me, the most important part is making people feel heard, listened to, and responded to. I think that makes a big difference, and that's something people don't forget. So I guess for me, the most rewarding moments are when I can connect with a patient or a family.
The service, to others, is such a deep-seated function in society. A compassion that is scientific, holding somebody's hand, when they are sick, it's all good. And it's, basis of all good doctoring. But the true compassion is the mixture of that and science. I'm actually able to change this.
The students who come here want to change things for the better. They want to make a better world. And that's a theme that really didn't exist, I would say, in medical education. Certainly when I went, it was all focused on an individual patient-doctor relationship, which is still critical, but students are thinking bigger than that. They're thinking about the system and the populations they serve and how to make healthcare better, not just individual care better.
And that's where medicine, in this sort of institutional way, is much more impactful, I think, than almost anything else I can think. You can change things in society in a way that otherwise you would not be able to. And education is a part of it.
Physicians are powerful advocates, and they can advocate for their patients in the clinic, but also more powerfully can advocate for their patients in the community.
They are amazing, aren't they? I'm so proud of them. It's such a good, personal, I think, and professional feeling that our medical craft is in good hands. Don't you think? Does it bring back any memories, perhaps? I think in the video as well as in the pandemic, we have seen that it is the flexibility, the adaptability, the nimble mind that has really made this into an opportunity to show where we fit and how relevant we are to the pandemic. And as I told the students and the faculty and everyone who would listen, we trained for this. We are built for this. That's what medicine is about. That you are able to build that arc of human agency in defense, in sort of a medical shield almost to the obviously agency-free virus. Anyway, next slide, please. So we had a number of the virtual things. You are not the only people that have everything virtual. So we had this is a snapshot of our class of 2024, and we obviously had a white coat placeholder event for this, and we plan, of course, to go back to the in-person. We like in-person when we are able. Next slide. The class of 2020, of course, was impacted by the pandemic as everybody else. And this is our virtual Match Day event. And many people, including myself, have seen this as one of the most emotional and most sort of personally invested. You see people's dogs and cats there, their parents, they usually, come to the to these events, but the pets don't, and it was different. It was different in a good way. Next slide. The commencement, was also online. We cannot share the whole video, but again, it was fascinating to watch the individual students and their families sending greetings and congratulations to one another, literally around the globe. And in some ways, as the match before, it was one of the most emotional commencements that we have ever had. Next slide. So we moving a little bit to the clinical enterprise. It is one of the unquestionable accomplishments of this medical school and this physician practice to be able to negotiate with Fairview Health System an agreement. We call it a definitive agreement, which is in place now for about 2 years, as a backbone for much more effective and much more functional relationship. And James Hereford, who is my co-leader in the mHealth Fairview partnership, has been phenomenal. And we really have ambition to get healthcare from where it is now to where it's supposed to be. Next slide. Most of you, I hope, would understand the healthcare today as a challenge. I see, and I was obviously trained on the other side of the Atlantic, but I've been here for 3 decades now, and have seen the clinical system from most of every aspect that you possibly can. And I see this as a failed business, first of all. The fact that it's business at all is an accident of history. But the way how patients, our families of patients have seen it is as a fragmented, expensive, unequal system, despite the fact that the American medicine is the best one in the world. There's no question in my mind that the academic medicine dictum has never been advanced better than in the United States. And with that, comes optimism that I think we are a little bit sped up by the COVID-19 experience this year, but it falls into the category that we would have to do it anyway, to move from what we have today to a healthcare that that is personalized, that is mass personalized perhaps, but personalized nevertheless. Because if you do what the healthcare system have tried to do over the last decades, which is scale, you make the lives of the patients and the providers more miserable, because it is in nature of that almost sterile and almost cookie cutter kind of scale that you can make it more efficient, but at the expense of the burnout in the physician platoons and dissatisfaction on the side of the patients. It has to be a lower cost. There's no reason why it should be this expensive. There's not a good reason. Somebody is making money off this. And as you probably know, the insurance companies this year have made an enormous profits, exactly because we were not able to do the usual book of business that we usually do, because we worked on the COVID. And I think it also has to become more nimble, more adaptive, more connected to daily life through wearables, through artificial intelligence, through machine learning, through ambient intelligence, through ability to have a symbiotic relationship between the artificial intelligence and human intelligence, because that's the only way, because it is not AI, and I'm a big fan of AI and machine learning, while it has enormous capability of processing phenomenal, superhuman amounts of data, finding patterns where I would not be able to find them. It will miss things that a practitioner won't miss. And it will also, I think, patients will want to see their doctors. So it is a symbiotic relationship between the two kinds of intelligences that will define some of the events this decade and decade to come. Next slide. One of the examples of the quick-minded collaboration between Fairview Health System and University of Minnesota was the Cohorting Hospital in Bethesda. This has been stood up almost as a army-like endeavor in 72 hours. And because we got the patients at the same site, we were able to do a couple things at the same. We were able to protect our nurses and our physicians in a much better way than we would ever be able with the very limited supply chain of the protective personal equipment at the distributed network. The second thing is we were learning essentially from every patient in a very rapid speed. And we were bringing this, and we are not the only ones. We were the first, and I think for a long time, only cohorting hospital for COVID-19 in the United States, but we were constantly exchanging information with the ICUs in Italy and elsewhere in Europe, in Seattle, in New York, and elsewhere. And so this was a distributed accomplishment. But what we were able to do with our teams was to improve the care in a measurable way. So the one number that stuck with me is the ICU survival. As you know, with the severity of the COVID-19 is a function of age and a couple other factors. So the older patients that we serve, their prognoses were pretty dismal. When we got the first data from Wuhan and then from Italy and then from Seattle, and our ICU in a very quick, couple of weeks has moved from what before was more like an 80s fatality rate to lower 20s, and that was incredible. And now it's actually even better than that. Next slide, please. The community always, needs to be considered. I think that we have learned better and smarter that the listening is really the education on that front. And we were able to connect with the community based on the foundations that we have made in the past. The one example is the medical discovery teams that have been put together from the report from the Blue Ribbon Commission that Governor Dayton put together, and they were very specifically built around what does the state want us to do, and these were the 4 areas where we were asked to help, and we got funding for this, and this has been a successful model. I was about to say a model, but it's already a successful model that made very clear that the team science is the only way to do things, made very clear that you need a support system for the teams so that they actually do accomplish the work that they can, and that they have the freedom to frame and reframe the problem in a way that without that critical mass of intellect and goodwill that you can have in a team like this, you would not be able to do. And lastly, they are connected by almost forcefully connected to the clinical enterprise. These are not islands of superior elite intelligence, sort of free floating out there, and reporting their number of Science and Nature and Cell papers every year. No, this is really very clearly aimed at the translational arm of all of this. Next slide. And we've seen this in that successful model applied in the COVID-19, where the testing, which was I mentioned to you the protective equipment, but the testing was a big problem at the beginning of the year, and the supply chains were essentially swallowed and cornered by private industry, and we did not have the simple, PCR that has been the mainstay of the diagnosis. So what we've done is PCR, as you probably know, is one of the simplest things, that I do in my lab and, my students do in every other lab. So we actually had the reagents collected across the university, got the testing together, and that's how we delivered the first bolus of the really relevant number of tests for the state of Minnesota. And that's why Governor Walz and his commissioners asked us to enter a partnership in the testing along with the Mayo Clinic, and I think we've delivered on this. We are nowhere done, but the fact that we were able to stand this up in a matter of days and then get the accreditation in very, very fast clip, and then get it back to the community is the reflection of the land grant mission. Next slide. Going back to the legacy, this is another hero of mine, William Osler, whose essays, I read and reread, and I have, I just admire, people who have been able and still are, I think, move seamlessly between humanities and sciences, and then make it into what I think has been one of the best role models for a clinician with the equanimity and for the patient, and how reason is such a liberating component of our lives. And he came to the university in late 19th century to open what you see here, which is the first building of the medical school. And I think that going through the 130 plus year history of the school, seeing people like him, like Abraham Flexner in 1910, Dr. Deal, that put together the first concept of the clinical trial, the glorious 50s with the pacemakers, with the stents, and 60s. I have to put this in with the bone marrow transplant. That's why I came here. And then the continued efforts on this is almost an obligation. I think it's a responsibility for us to be guardians, never owners, but guardians, and like good guests that will leave this place, the virtual and the physical, in a little better shape, a little better service, service ability to the community, and yes, this is to be thought about in a lens that incorporates the the past as a prologue for where we should go, and people that we have today around us, as the bandwidth, that we can incorporate, and attract, incentivize, almost energized, by the challenges that are in front of us. But really, it is all done in the view of our children and our grandchildren. I have a 2-year-old granddaughter. I think about this quite a bit, and how what is to come is really yours and mine to discharge. So thank you very much for listening, and I'm happy to answer your questions.
Thank you, Dr. Tolar. We invite our alumni to submit any questions they may have for Dr. Tolar through the Q&A function found at the bottom of your screen. We do have a few questions that were submitted beforehand. Dr. Joseph Westermeyer asked, you touched a little bit on some of the statistics, but how do we stand in the U.S. in relation to other medical schools as far as medical students passing their boards, residents filling seats in residencies, fellowships, and various research hallmarks?
Excellent question. Thank you. So the first one is how actually our students do in the subsequent parts of their training if they when they enter the medical school. And what we have seen is that they are at above the median for the step 1 and step 2. And what we do see is that they get better than expected in the step 3. This is sort of a value added on the trajectory, and we had just earlier this year had the LCME visit that looked at a lot of the components that go into it, and it is a credit to the Office of Medical Education that many of the supporting systems have been enhanced so that the trajectory of that gain, if you will, value added, has been upward. We had one of the best matches ever this year, and we consistently score above the where we were, which is one metric, and also in the competition with other medical schools. I mentioned to you that that Minnesota environment, there's something, in the water of the 10,000 lakes that's sticky because people come and stay like me. And the fact that 70% of physicians are trained in our medical school and stay in Minnesota, in the state of Minnesota, 37% of the physicians in greater Minnesota are trainees of this medical school. And we are ranking quite well, as you have seen, with all humility, in the NIH ranking. The ranking that I am almost most proud of is the composite ranking by Fritz Mullen, who asked a question which always troubled me before I read that paper, how the medical schools do so many things at the same time. And what you have in the United States is, out of these 150 schools plus, what you have are schools that are almost split between those that are research universities and research medical schools that are scoring very well in the NIH ranking, and they would be sort of in the top quartile for the NIH ranking that I showed you some time ago, and they don't really do well in the primary care and training for the primary care physicians because that's not their focus. And then you have schools that are focused on training the primary care physicians, and they typically do not focus on the NIH. So if you take these two metrics together, they're almost they're not exclusive of each other, but they are in competition with each other if you have limited resources like we all have. There are only 4 schools in the United States that are in the top quartile for both of these metrics. University of Minnesota is one of them. And then what Mullen has done, he added a component of a social metric to it. And he asked, what if you also add a component that has how many students underrepresented in medicine do you have, and how many people that you train, physicians, do go to places where underrepresented minorities and communities are. And if you add the 3 metrics together, so again, NIH, number of primary physicians, and this social mission metric, there are only 2 schools that are in the top quartile. One is University of Washington and one is University of Minnesota. And I think, that reflects almost in the best measurable way, the glorious and noble, not just goal, not just the legacy, but accomplishment of this medical school. Maureen?
Thank you, Dean Tolar. We had another question submitted by Dr. Hansen. How do we assure that everyone in Minnesota can obtain equitable, quality, and affordable health care?
That is a phenomenal question. If I knew the answer and if I had the resources, we would be there. This is a challenge that has, it's one of these things that, it's one of these challenges that are so obvious that need to be solved. And one of the challenges that is so complicated and complex that I don't think that there's a simple solution, because if there was one, it would have been done already. It's one of these challenges that you are obligated to stay on. You cannot desist from working on the problem, even though you may not have an immediate, within the reach of your hand, an immediate solution that you can reach for. What I think is that the best way to get there is through the democratization of healthcare and through changing the business model. And the way to do this is really to not taking that lighthouse of American healthcare business, which is a crumbling one, in my opinion, and put a new coat of paint over this, as many have tried, but rather go in what another hero of mine, an economist named John Kay out of Oxford, called obliquity. You much better solve these wicked problems by going in an oblique way than the direct way. And the obliquity that I see is the ascent of the digital age and the ability to make it a personal ownership of the patients that can own their data. They can make their choices. For the first time, you would be able to actually allow people to make the informed market choices. You focus on health rather than on sickness. You understand the health as a composite of what happens in the human body from the clinical perspective, and nutrition, geography, mental health, and all the other components. And you delegate some of the functionality into the hands of the people that are served by that system so that they can make informed decisions. And it's almost like Adam Smith, that it's not a direct effect of the system. It is really out of the good work of the components of the system that you will end up with that invisible hand that will improve the access to healthcare and the quality at the same time. A specific, example of that is, of course, telemedicine. Our ability to extend some of the knowledge of the consultants, perhaps, and on the screen has been tremendously aided by the COVID-19 experience with virtual visits. And we are already partnering with corporations or conglomerates, that have great interest in connecting people, not for health reasons necessarily, in greater Minnesota and upper Midwest. And I think it's the self-reinforcing trajectory with which we get. The other component of this is the Minnesota Cancer Center trial network. So as an oncologist, I can tell you that the difference between the incidence of cancer in state of Minnesota is about the same anywhere you go. The mortality is much greater in places that are distant from big cities and big hospitals. And that's just not acceptable. And what we have done some years ago, and now we actually have a well-functioning network, again, with Mayo Clinic and other healthcare systems in the state, is this Minnesota Cancer Center Trial Network, which essentially offers the same treatment that would be offered to somebody in Metro here in Twin Cities to somebody who lives in International Falls or in the Arrowhead or in the western parts of the state. And we already see that there's not just a tremendous response, from the providers and the patients alike, but we already start seeing some quite positive trends in areas where we have seen none before.
Great. Thank you so much, Dr. Tolar. We have a question from Dr. Bill Wallen. Will there be increasing teaching around psychological trauma care and the treatments to reduce the effects of adverse childhood events that manifest later mental and physical health problems?
It's an excellent question. Thank you. Thank you, Dr. Wallen. Absolutely, yes. The understanding of how mental health is playing into the physical health, has been open to, I think, all of us through the last century. But the appetite and the bandwidth for actually doing something with this has only been accessible to us in the recent years. One of the examples of how University of Minnesota Medical School is leading internationally is a recent example of the Institute for Developing Brain. So this came about in my team some 3 years ago when in discussions with then a dean of the College of Education and Dean Quam, we were thinking about having a number of components that can be relevant to these adverse childhood events. And we just need to somehow put it all together in a harmonic way. And what we have or had is, one of my teachers in the NICU was Michael Georgiev. And he was the one who taught me how to intubate very small people and put central lines in them. But also his lab has worked on a iron deficiency and how that iron deficiency prenatally and early postnatally impacts development of brain, murine or human, especially in the sort of thalamus and hippocampus areas, and how long-standing the impact of the lack of this nutrient, this metal, or other micronutrients can be. At the same time, almost in parallel, you have the Center for Magnetic Resonance here with Camille Ugurbil and others, which is probably one of the two leading centers for magnetic resonance in the world. And for the first time in history, they were able to map non-invasively, of course, the connections in the brain in what's called connectome. So the first one was the adult connectome that has been done in collaboration with others, but then came baby connectome, which is the very early, sort of an 8-month-old child, and, in that realm, and then a teenage connectome. The two spurts in the brain development and other developments, the first, in the very beginning of life, and then the second in the teenage years. And then we had the CEHD component and the community engagement. And then we had the phenomenal gift of being able to attract one of the leaders in new psychiatry. Sofia Vinogradov came from San Francisco, and she's with David Reddish and with several others. She's the leader in how to change the say hebephrenic schizophrenia, first soft, quote unquote, soft signs of the young adult psychosis into circuits that are in that connectome place that are more resilient and more robust, more protective against the first onset, first episode of the psychosis. And now what we have done is we've taken that resource, and as opposed to just putting people around, in sort of a distributed network that may or may not talk to each other, we elevated it into the question that you just asked, which is how can we prevent these disorders of despair that are the ones that result in adulthood and that are the suicide, obesity, addiction. And that actually has defined the one of the most troubling, in my opinion, statistics of the recent year, which is that the lifespan of an average American, the same lifespan that doubled between 1900 and 2000 from about 40 to about 80, is going down. This is the first time since 1918, which is the year, of course, when the armistice of the First War was signed and when so-called Spanish flu has been circling the globe and claimed millions and millions of people. This is for the first time since that time that we have 3 years in the row, we had people dying and in unprecedented numbers, and that's reflected in the lifespan of the average American going down, not up, as you would expect. And all that mortality is in the midlife mortality bracket. So if you look at this and you take what others call maladapted adults, people who just cannot make it into a productive life for one reason or another, and you backtrack, you go to these 10 steps of the adverse childhood events, you can have a fairly good prediction of who is going to end up in trouble 20 years hence. And these events are tragic, but not difficult to understand. Death of a parent, addicted parent, jailed parent, some, of that magnitude. And if you have a number of these events, adoption is one. If you have a number of these events stacked, then it's very likely that that person will do poorly when she or he is in their 20s and 30s, and perhaps will never be able to turn this around. So that's why we have started the Institute for Developing Brain. That's why the Masons were intrigued enough to really make a phenomenal gift to the project. That's why we were able to acquire the Shriners Hospital, where I used to attend in the ICU. So I knew the place, and that's why we are in a position to, I think, at the same way as we did in medicine with vaccines, where as much as antibiotics are phenomenal, the real change in infectious disease were the vaccines. So by the same thought, intervening at the time of what we call first 1,000 days after birth, and sometimes even prenatally, will be the most effective, perhaps the only effective measure that societally we can do in this. And before I leave this, the second or the third almost structurally symmetrical work, that has not been yet started, but I'm putting together the pieces to have the team to be able to accomplish is in geroscience, because for the same reason, if I have the typical patient in our healthcare system and in other is 74-year-old with 3 comorbidities. As we all know, it's very difficult, to turn around, some of these comorbidities, especially as they play out together. If you are able to intervene, not at 85, but at 55, with what we, for the first time, again, that was one of the medical discovery teams, the Institute on Biology of Aging. If we, for the first time, we have availability of these senolytics, essentially medications that will remove senescent cells from tissues and in return allow the homeostasis of that tissue and also allow or prevent the exhaustion of the immune system, we may be able to not extend the life, but extend the quality of the life.
Thank you so much, Dr. Tolar. That's all the time that we have for questions today, but I want to thank you so much for sharing with our alumni the incredible work that's happening in the medical school and with all of our partners. Alumni have many reasons to be very proud of their alma mater and of the role that they themselves play in making it great. So thank you so much.